So we always like to have panel discussions at ACT because we find that it really helps to give an opportunity for people to think about many of the questions of the day. And three excellent presenters, Dr. Kelly Price from MCFD, Dr. Georgina Robinson from POPARD, the Provincial Outreach Program for Autism and Related Disorders, and Dr. Grace Iarocci from SFU. Both Grace and Kelly are registered psychologists, and Georgina is a school psychologist, but I asked them if they would briefly introduce themselves, and I've asked them, or we've decided that the focus of today's discussion would be best on the ethics of providing CBT to children and youth with autism, and adults for that matter, because it's been a tremendous issue in the province of families not being able to access for their children and adults not to be able to find professionals who have an expertise in working with autism and CBT. So that's the reason we've developed this series. And that's why we're now trying to focus today on these things. Now, Dr. Kelly Price is going to start us off today.
So I'm the senior psychologist for Child and Youth Mental Health Policy, and I'm also, for the past 10 years or so, I've been a psychologist doing diagnostic work for kids with autism, mostly in Island Health. So I have lots of experience on the diagnostic side, and now moving more to the mental health side. So there are two different worlds here. One is the side of treating autism, which is done through Children and Youth with Special Needs branch of MCFD, and then the other is treating their mental health issues, which is done through a completely separate branch of MCFD called Child and Youth Mental Health. And of course, a lot of you are from Child and Youth Mental Health here, so a lot of you will know about this. But Child and Youth Mental Health has about 90 clinics throughout the province, about 600 clinicians. The government has recently increased the funding substantially, so there's going to be 120 new clinicians over the next 3 years, so adding about 40 brand new clinicians per year, and that's over and above any retirements and resignations and that type of thing. So there is some increase in funding to child and youth mental health that will hopefully start to address some of the access issues. But the access issues are really significant. The wait lists for child and youth mental health are huge. And when you look at the question of why is it sometimes hard to get kids who have autism into a child and youth mental health program, you have to consider some of the other issues that the child and youth mental health program is dealing with. So unfortunately, we're not always able to address mild to moderate mental health needs because the need for services for kids with moderate to severe needs is very high. So you can imagine the intake clinician who gets a call from a parent of a child with autism saying, I'm concerned that my child might have an anxiety disorder in addition to their autism, versus someone who's phoning and their child is actively suicidal. So that's quite the distinction, but the issues that families of kids with autism face in getting services for their children are not unheard of compared with other kids who have mental health issues. They're just 600 clinicians in a province of 3 million is not a lot. So working on it, but it's a challenge. There's one initiative that Kimberly Armstrong is putting out in Surrey, trying to provide more of these kinds of care within the Child Youth Mental Health Program. And there's lots of child and youth mental health clinicians in the room who are going to be taking this back to their clinics and trying to do more of this. So I'm very happy to see that. One of the other issues that I think is salient is that clinicians are taught pretty strongly throughout their training, and then it gets reiterated by all their colleges that they should not practice outside their scope of competency. So we get taught to only do what we know how to do. And there's certainly no lack of kids who need mental health services, the very generic mental health services. So it's pretty easy for a clinician to say, I don't know much about autism, and frankly, I'm very busy and have lots of other kids that need my services as well, and so then not to challenge themselves much. So I'm happy to participate in a day like this, because really I went through the codes of conduct from the different colleges that are relevant. So like the College of Psychologists, the counselors, the nurses, the social workers, and they're all fairly similar. So they say, don't practice something unless you have some training. So here we go today. We're getting some training. So then maintain your training. So come back to things like this in the future, and partner with people who are doing this as well. So look to your left, look to your right. Now you have someone who you can do co-supervision with. And then, the colleges are pretty forceful in saying, too, that you should refer out when something is outside of your scope. But the other thing you have to recognize is that if you are the most qualified person on your team or in your program or in your community to do this type of work, then you may also have an ethical imperative to do that. So the College of Nurses and the College of Physicians are very clear that that you can't just say, no, that's not part of what I do. And I think that's less obvious in the College of Psychologists, College of Social Workers, clinical counselors codes, that if you are the most qualified person around and you can't identify someone that you can refer out to, then you may have an ethical imperative to provide whatever service you can. And I think that there's literature, and maybe you can correct me, but I think that even if you don't really know a whole lot about autism and you kind of just do regular CBT, you're unlikely to do harm, and you're probably going to be helping the person. So the access issues are complicated, but certainly we know about them and are working on them. And now we have a Ministry of Mental Health, so maybe that will help. One of the other things I noticed, especially doing diagnostic work, is that kids I don't know if it's a BC thing, but oftentimes mental health symptoms are presented in terms of sensory sensitivities or sensory stuff. And so a lot of the time when I hear about sensory issues, it's not so much a sensory issue classically as a description of a mental health issue. So a lot of phobias that kids who have or don't even have autism might be put forth as being as a sensitivity when they're actually a phobia. And a lot of other anxiety disorders I find get treated like that as well. Sometimes ADHD is described as sensory seeking or those types of things. So I think I think there's a reluctance to refer to things as mental health issues sometimes, and that we sometimes start with this notion of it being a sensory need or a sensory sensitivity or some such. But I think it's important to address those types of things as a mental health issue. I remember one child I worked with who had what was described as a sensory sensitivity about water and bodies of water. And I thought, well, this sounds more like a phobia of water. And we had very different, it really changed the focus of treatment. So a sensory sensitivity to water was something, well, then you just wouldn't approach water, or you'd, not make the child ever go swimming. But if you put it as a phobia, then of course you're going to do some exposure, and eventually the goal will be to get them in the water. So, and probably more functional. And then I guess lastly, as we embark on this new Ministry of Mental Health, I know that one of the things that sometimes puzzles me is that our autism funding programs cover things like physiotherapy and things that are more medical/health related than mental health. So you can't use your autism funding to pay for mental health services. And I wonder, to what extent that is really just one of those stigmatizing things around mental health that we have to rethink.